Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So I hope everyone had a good July. We're now into August. If you could believe that, that is just crazy to me. But we are well into August, the hottest month of the year. Yeah, hard to say, though, because July was pretty darn hot. But hopefully you're taking some cover there, or you live in a state that isn't too hot and you can get in the pool or get outside and hopefully some fresh air. But what came out today, and this is kind of where I'm going with my topic, is we had some new guidelines. The official guidelines were released for the calendar year 2026 for ICD-10-CM. Now remember, I shouldn't have said calendar year, I should have said fiscal year because it is FY. And it is effective October 1st of 2025 through September 30th, 2026. And so this is the fiscal year 2026 is what these will be official for. So, and what they'll be effective for. So you can find these not only on the CMS website, the National Center for Health Statistics, NCHS, also CDC and AAPC, you name it, everyone's got it. But these are the guidelines. So they're talking about how you're using the codes, and before they give us all the codes. We've already had kind of an insight or update into what codes will be coming out, but they've given us now how to use the codes. And these changes made to the official guidelines, they may affect your diagnosis coding and how you apply what you know and some of these new codes within your practices. So I wanted to give you kind of a snapshot and take a look at some of these new guidelines, because some of them, and I don't know if you noticed this, I think ever since COVID, sometimes I feel like they've lost their minds on some of the applications on how to report services or how to report some diagnoses. And so I always read it with a fine-tooth comb because I'm like, what are you trying to tell us here? So there's some new guidance on multiple sites coding. And let me say that again, multiple sites coding. So ICD-10-CM has added guidance defining multiple sites, explaining that coders should follow chapter-specific guidelines for assigning codes for multiple sites. Now, if there aren't any chapter-specific guidelines, then you should assign codes according to the specific individual sites when documented. If the specific sites aren't documented, assign the appropriate code for multiple sites. And make sure you tell your physicians this, because your providers are going to need to be a little bit more specific. The biggest revision that I saw to the ICD-10 official guidelines involves the way coders select and sequence human immunodeficiency disorder or virus, so HIV codes. CMS and NCHS made several changes to the guidelines in its section IC1A2, including coding changes for various scenarios involving patients before, during, and after an HIV diagnosis. And so make sure you're reading up on that, because the changes are kind of interesting for a positive status patient. So let me just give you an example. The first change involves an insertion of a new guideline, IC1A2A, which tells you to assign B20, so the human immunodeficiency virus, HIV, hard to say, disease, when physician documentation indicates the patient has acquired AIDS, so acquired immunodeficiency syndrome, HIV, or, and I'm quoting, if the patient is treated for any HIV-related illness or is describing as having any condition or conditions resulting from the patient's HIV positive status. So you're coding it along with whatever the patient has in addition to that, and if there are not just HIV, but also acquired immunodeficiency syndrome, which is different than before, because as we know, HIV is the virus that leads to AIDS, but you don't necessarily have AIDS right away. So it's an interesting clarification. It also added a clarification under C that you can assign B20 as a secondary diagnosis for patients with HIV who have been admitted for an unrelated condition such as a traumatic injury. And the same is now going to be true for other documented conditions per the guideline revision. Now, I'm not sure if I like that, but that's what it's saying. If it is in the notes, in the documentation, that the patient has a positive status, always keep that in mind. And then also under the new guideline at this section 2E, you're told to apply the code, and I quote, when HIV positive test or similar technology is documented and there is no documentation of symptoms or HIV-related illness. Okay, so that, unquote, so that's the Z21 if it says the patient has asymptomatic human immunodeficiency virus infection status. So the status is when there's a positive HIV test, if they test positive, or if there's some kind of documentation that relates to that illness and in a positive, obviously not positive way, but positive that they have it way. So if you are in infectious diseases, that's going to be an important clarification. Now, the one I'm actually most excited about, and I know that this is not going to be exciting for a lot of providers who rely on their HCC bonuses, but remember, you're in the business of medicine, and hopefully you're a provider that went into medicine to cure people, to hopefully, get them better. And so we're going to be reporting type 2 diabetes a little bit different when it's in remission. So the guidelines added a new subsection regarding type 2 diabetes in remission conditions to coincide with the new codes identifying this status. So subsection IC4A1B instructs you to assign E11.A, capital A, type 2 diabetes mellitus without complications in remission when the provider's documentation indicates the diabetes is in remission. If the documentation is unclear as to whether the type 2 diabetes has achieved remission, query the provider. So, and it says that in quotes in the guidelines. So an example of when the documentation is unclear would be if the provider wrote resolved, which is not the same as being in remission. So this is interesting because they're using a remission, which I would have assumed is resolved, meaning that you're kind of done with it, but it's almost like they're looking at it as a cancer, meaning that it's not a current problem, but it still exists somewhere in the body. And so that's where you have to query the physician. Is it in remission? Do you expect it to return? But right now, the patient's there's been a change in maybe medication. There's been a change in the risk of that patient along with the guidelines of what you're doing with that patient where it's in remission. And pretty much it's been stable for a long time. However, the patient's treating it, whether it be on, drugs or I guess drugs, insulin, lifestyle change, whatever, and their A1C has been coming back under 6 for quite a while. That could be considered remission. It just depends what the provider wants to look at there. So that's an interesting diagnosis, and I think we're probably going to still have some issues with that. Now, being primarily a cardiology coder, even though, I do deal with 8 specialties primarily, handling hypertension with heart disease conditions. So the section IC9A1 deletes the, in quotes, or following the I-50 heart failure and lists I-51.4 myocarditis unspecified instead of basically saying, other ill-defined heart disease. And so unspecified remains in the guideline. And so it also adds I-51 point with a dash there to say there's going to be a different digit. Complications and ill-defined descriptions of heart disease to the instruction, directing you to use additional codes to identify the patient's heart condition. I always think coding heart conditions, especially when there's underlying manifestations such as hypertension, such as kidney disease, all that, is one of the hardest to code because the providers don't give us enough information. So they've also moved around some sentences in the guideline that talks about, for example, in I-13, hypertensive heart and chronic kidney disease are combination codes that include hypertension, heart disease, and chronic kidney disease. So that was at the beginning of the section. Before it was at the end, which I thought was ill-placed because you wouldn't know to code it until you coded it incorrectly. So that was actually helpful to move things around a little bit. But they just want you to really look at specific heart conditions and how they relate to other heart disease manifestations like chronic kidney disease or hypertension when you're coding, because there are going to be a lot of combined codes. Also there's some new code first for prophylactic organ removal codes, clarifications on anti-neoplastic therapy diagnosis codes. They just got more explicit directions for patient admission encounters. that are mainly for administration of anti-neoplastic chemotherapy, immunotherapy, and radiation therapy. So it's helpful because now in the guideline, it talks about when the main purpose for the encounter is to administer chemotherapy, that you're going to use codes from the section Z51 as the first listed diagnosis. And they didn't before. They were using cancer codes. So that's interesting. The BMI code, so the body mass index code, there's a revised guideline for situations in which the patient's body mass index is considered appropriate. The guideline now says that to use a code from the Z68 section, quote, BMI code should only be assigned when there is an associated reportable diagnosis, such as specific obesity or anorexia documented by the patient's provider. And so if the patient pursues an encounter for an associated reportable condition and the documentation shows the patient's BMI fluctuates, as a coder, you should assign a code reflecting the most severe value according to the updated guidance. So it's interesting because I do see sometimes, BMI is a secondary diagnosis without a diagnosis for a specific obesity or a specific anorexia diagnosis. And so that's an important clarification, that BMI should only be there when there's a reportable diagnosis that reflects why it's there, not just, putting it on there. I think that could have happened with some patient complaints. And actually with all the new weight loss drugs, I'm sure that was also a big issue that needed to be clarified as well. So that's basically what I wanted to update you on the ICD-10 stuff. But I also wanted to talk to you a little bit about something I'm seeing, as you always get my fun jewels of what I see when I'm auditing. And one thing I'm seeing right now, and this is coming from a very large healthcare provider in the country who I will not name, but they are looking at discharge summaries. So the discharge summaries are 99238 and 99239. And what I've noticed in this payer audit that I'm doing is that the 99239 is used 99% of the time. The doctors use a macro or smart phrase at the very bottom, and basically it just says the same thing every single time. It says that I spent 45 minutes reviewing the chart, seeing the patient, and discussing the options, and every single patient. But then you don't see an exam. You don't see anything on there. And I know we don't count anything towards the exam as far as leveling. And discharge codes are based on time, either less than 30 minutes or more than 30 minutes. You have to have total time. But when you have a lack of exam, when you have cloned statements, or you have duplicate time statements for every patient, you're looking at malpractice situations. How can you not have an exam, but you know the patient's okay to be discharged? That's what I'm looking for as an auditor. So you have to make sure that you've got that information and these canned micro-timed statements. There's no way you're spending 45 minutes with every single patient for discharge. If you are, you're losing money for the practice. And so when you have to put time in there, what you're doing if you're using an overtime-based code. And I don't like to also see phrases that are right out of the CPT AMA guidance saying less than 30 minutes was spent or more than 30 minutes spent. No, remember, go back to your published guidance. It says you have to put total time and what those activities were. So, and you have to know that if somebody, a payer sees, or an auditor, or, let's say it's a formal audit, a UPIC audit or something, and they see something that says consistently the same time for every single patient. It reminds me of that Staples commercial where you're pushing the Staples button every single time, basically saying, okay, I'm punching out now. And that's not how medicine works. Remember, patience over paperwork. So there are going to be times when the patient is stable, they are, they're ready for discharge, and the patient can tolerate activities of daily living. You're going to say, see maybe medicine instructions, and you need to know what you are specifically instructing them for, especially if they're in a post-op. And hospitalists do this all the time, and they don't realize that, just because the hospital requires you to see the patient doesn't mean you get the code if you don't explicitly say what you are doing in that just discharge process. But that could be a problem. And so make sure that if you're using the highest valued code of a time-based code, that you are specific not only to your time, but to your activities and to the patient. reflect the medical necessity and don't just make it an administrative code where you reviewed everyone else's chart and then you're sending the patient on their way. That's not okay. So you have to show what you did in that documentation, and always remember, too much of a good thing is too much. So you can't be billing, or you shouldn't be billing, the highest code every single time, because that's not believable. And it's important to know that the insurance companies, the payers, especially Medicare, is looking at time-based codes for inappropriate application. So, what are you actually doing with that patient? Okay, well, that is it for me today. I think I kind of covered the two topics I really wanted to. On a personal note, I'm always looking for some really good, streaming shows to watch in between my baseball and my football and all that, and football season's coming up, so I'm pretty excited about that. I started a show that actually was something, I can't believe I missed it, because I love political shows. I'm crazy about politics, which probably makes me weird, but that is who I am. I started watching Madam Secretary. It's on streaming on Amazon. It's really good. It's a cross between Designated Survivor, which was only out for 3 seasons, which I really liked, but that was kind of scary. And then it's not really West Wingy, but you can tell it's a little bit, probably Democratic instead of Republican. But I like the main characters, Tia Leone and Tim Daly. And I really like the dynamic with the kids because, as you know, TV kids can be brats, but I really like how they deal with their kids, and in fact, don't let them be bratty. And so I kind of like that. But it's interesting just seeing the inner workings from a TV perspective. Let's always put it in perspective of how some of the things work in politics. Now, for those of you who are like, I've had enough politics, it's all over social media, it's all over the news. I get it. But this is based in 2014 to 2019. And so things were a little calmer then. So just know that it's interesting. So if you're looking for a new show, take a look at it. My husband and I both really like it. We actually binge watched like 3 or 4 episodes in a row. And it's like, wow, this is really good, really well written. Okay, that's it for me. And I hope everyone has the great rest of your week. Make it a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.